The topics that I'm going to touch on during this presentation will include pathophysiology, symptoms, presentations, diagnosis, and probably management as well. I thought to make it as inclusive as possible and as interactive as possible to include probably a big part of it as a quiz, but this is not to test anyone's knowledge. So it's just to make it a bit of fun, that's all. So before we start, I think we fairly all know that cystic fibrosis is quite probably common autosomal recessive condition. 1 in each 2,500 babies born will have cystic fibrosis, and it's genetic disease. It can be inherited. Anyone knows what is the gene that is implicated in cystic fibrosis? What's the gene's name?
CFTR.
CFTR. Ignore the others, these are completely made up. So, CFTR. Does anybody know what CFTR is short for?
Calcium channel gene?
It is close, but
Cystic fibrosis?
Yeah. Cystic fibrosis transmembrane conductance regulator.
Okay.
This is what CFTR stands for. And anyone knows what chromosome it is on?
9?
2.
Do we have? Okay. Do you have other answers? 7.
Oh,
it is on the long arm of chromosome 7.
Yeah, 7.
That is true. And what does it regulate?
Calcium.
Calcium. Do we have other answers? Huh?
Chloride.
Chloride.
Oh,
That's
right.
chloride. Right. So CFTR.
It's a boy versus girl.
Exactly. You can have some teams probably, but he is going to be the only boy. I can probably slip you the answer. So CFTR is a gene that encodes for a protein that is also called CFTR. Essentially, what this protein is, after it gets produced, it migrates to the cell membrane, especially the cell membranes of the epithelial cells in various organs. And interestingly, it's not just one mutation that happens with this gene. Up to this date, I think there's more than 1,500 mutations that are documented and known to be causing cystic fibrosis. It facilitates or regulates the transport of chloride ions across the cell membranes of the epithelial cells. And after chloride goes from the inside the cell to the outside of the cell, water follows, and that sort of makes the mucus on the cell surface kind of watery and easily to be removed. And this is essentially what happens. The opposite of this is what happens when you get a faulty CFTR for any reason. Sometimes some mutations, actually in the most or the commonest mutation of the CFTR gene, which is, in this question, anyone knows what is the, please senior doctors don't answer. Anyone knows what is the commonest? First one. Do you have any other answers? It is the first one. It's Delta F508. It has a fancier name now, PHE 508 del, or something like that. In this particular mutation, what happens is that it fails to migrate to the cell membrane. And this one, the next one, is actually another recognized mutation in which the CFTR protein, it does migrate to the cell membrane, but it doesn't really open well for the chloride to be transported. These other two, you can see by this Euro 2024, it's completely made up as well, so these are not mutations. What organs that these mutations happen in and affect primarily of these?
Lungs definitely.
Mm-hmm.
4 definitely.
Mm-hmm.
Pancreas also. I'm not sure about the kidney.
It's all of them. It's all of them, and also to a degree in liver and intestinal cells as well. It's the pathophysiology in all of these organs is kind of the same. You get very thick secretions because there's no chloride transport to the outside of the cell. There's no water that follows. That mucus becomes very thick and viscid. It doesn't easily get removed or brushed as it naturally happens in normal cells, and this invites all sorts of pathologies as we are going to see later. So a little bit of a screening. Anyone knows what the screening test for cystic fibrosis is?
Is it 1?
Sweat
Chloride. Do we have any other answer? Screening. Mm-hmm.
Screening would be the blood.
Yeah, that's the correct answer. It's the day 5 blood spot. It has another fancy name. Anyone knows? It's actually number 3. So these two are the same. The 2 and 3 are the same. Day 5 blood spot is the immunoreactive trypsinogen, and when it's raised above the 99.5th centile, these patients go on to have DNA analysis. The immunoreactive trypsinogen. The confirmatory test, on the other hand, is the sweat chloride test. Measures the amount of chloride in sweat, and if it's raised particularly over 60 millimole per liter, that is when you have a positive or confirmatory test for cystic fibrosis. However, screening didn't really make things easier. It made things a little bit complicated because some babies that would have raised immunoreactive trypsinogen, but they're merely just carriers, and some babies would actually have equivocal confirmatory test, like the sweat chloride test. It would be equivocal from 30 to 60 millimole. If it's below 30, it's negative. If it's 60 or more, it's positive. If it's between 30 and 60, it would be equivocal. Anybody heard of the term CF-SPED? So CF-SPED stands for cystic fibrosis screening positive inconclusive diagnosis, in which you will have patients that, like the ones that I just talked about. Sometimes the confirmatory test would be just equivocal. Sometimes the DNA analysis wouldn't, because to confirm cystic fibrosis for the patients as well, you'll need to have, with the DNA analysis, you will need to have at least 2 mutations that are known to be causing cystic fibrosis, and sometimes patients get only 1 or 2. One is known and 1 is not known. So all sorts of stuff going on there, and there's a huge debate about how to approach the management of these patients, but we're not going to dive into this.
Can I ask a question?
Sure, if I know the answer.
Back to your previous slide.
Yeah.
So do all babies, because I never quite understood how it works, so do all babies that are positive on their blood, on their Guthrie, go for DNA? Don't they come for sweat test?
I think they all go for DNA analysis.
Really?
Yeah,
Oh,
I
okay.
think so. Yeah. And if they are found to have 2 or more, that's confirmation that they have
Yeah.
cystic fibrosis.
And
So
they don't
DNA
have
analysis.
the sweat test?
I think DNA analysis can be, in a way, and probably
I thought it's not.
yeah, can be a
Plus.
confirmatory also
Yeah.
as sweat
Maybe
chloride
DNA.
test.
Maybe
Yeah,
DNA.
yeah.
Okay.
So, to touch on the cystic fibrosis presentation in pediatrics, it has a long spectrum. It has a long spectrum of presentations, amongst which, and the most commonly and the earliest.
They're just doing teaching.
Oh, teaching.
Yeah, yeah.
Yes, okay.
Oh, but you're at least be there.
Amongst which, and the earliest presentation of cystic fibrosis is MELLITUS, as I'm sure we all know. This is a case about a 2-day-old boy brought to the emergency department by his mother after becoming inconsolable with abdominal distension, has not vomited or passed his first stools, was born to a 27-year-old woman via spontaneous vaginal delivery, no perinatal complications. Mom was not able to attend prenatal care visits to receive appropriate screening. Has undergone radiograph studies which were abnormal and showed what it showed. So this is MELLITUS. Anyone knows the name of the radiograph that confirms? Again, registrars, please don't speak. That confirms the MELLITUS. It's contrast enema, and this is how it looks. It's quite fancy. So, proximal to the obstruction, you'll see all the dilated bowel loops, and then after the obstruction, distal to the obstruction, you'll have very thin colon. That's why it's called actually microcolon, with all the inspissated mucus and stools there. And these babies, sometimes we get with the contrast enema, can be actually therapeutic as well, can probably break down the stool, but sometimes they will need operation. Question 8, and this is sort of to go into another presentation for cystic fibrosis in pediatrics. An 8-year-old girl is referred from GP with history of persistent wick cough, received multiple courses of amoxicillin with no resolution, had a recent episode of vomiting and diarrhea. Mom was told that it was due to likely viral illness. Mom denies loose stools now, except occasionally. On examination, she's got scattered bronchi bilaterally. However, she is growing well along her centiles, and there's mild finger clubbing. There's no family history of cystic fibrosis, but maternal uncle had COPD. Is that likely CF or unlikely CF? So, just for the sake of time again, sorry, I'm just going to dive into it. This case, I particularly put it here just to draw attention to two important points. First one is that it's a bit unlikely for a school-aged children to get persistent wet cough. It's not as common as it happens in the preschool children. Preschool children usually have colds that run into each other all the time, but if it's a school-aged children and having persistent wet cough, that should draw your attention to probably the probability of cystic fibrosis. What you should be doing here, and you shouldn't be fooled by them not having other symptoms probably of cystic fibrosis, because nowadays we're coming to know about all the new mutations. Of these mutations, what are called residual function mutations, in which that some organs would function completely normally. These patients can be pancreatic sufficient, but some other organs they don't. So just dive into the history, ask about the family history, look into other symptoms as well, like finger clubbing. This is quite important, COPD, because if you knew that screening tests were actually introduced in 2007, so a big part of the population were missed in the screening, and it would be quite often that people would develop COPD because they actually had CF, but they didn't know because they weren't screened for it. So COPD would be a complication of CF. Other presentation would be probably feeding difficulties. Reflux is quite common in babies with cystic fibrosis, but luckily enough we have proton pump inhibitors, which are very, very beneficial in cystic fibrosis and reflux. They treat reflux well, and the cherry on the top is that they actually help in absorption of creon, which has the pancreatic enzyme replacement therapy. By the way, creon dosing, when I was reading on it, it's absolutely dark art. It is worked out based on many factors like lipase units per kg, dietitian's intuition, sometimes luck. So we're not going to dive into it as well. Malabsorption and failure to thrive is also a big part of it in pediatrics, because in the pancreas loses its exocrine function. There's no lipase, there's no amylase, so it becomes harder to break down the fats. They don't get absorbed. That's why often these babies present with loose stools, probably stools or children that present with stools that are hard to flush because of all the fat in them. And the defective intestinal absorption ultimately lead to failure to thrive for them. Another thing is diabetes mellitus. I know that it's primarily the exocrine function of the pancreas that gets affected, but the endocrine function as well, as a consequence of this, because of, again, the thick sticky mucus can lead to pancreatic scarring, and that can affect the endocrine function. And there is a separate entity of diabetes that's called CF-related diabetes mellitus, which happens in 20% of CF patients. Bronchiolitis. These babies can also present with bronchiolitis, which can be quite same as the non-CF patients. However, it can last much longer, up to weeks probably at times. And there is growing evidence that these babies can be at high risk of having Pseudomonas infection as well. So this is why it's very important that these patients go on antibiotic courses. Coughs and colds as well, they will probably come with coughs and colds all the time. That's why I drew attention to the patient, the 8-year-old patient in the previous case. And there's also growing evidence that RSV, co-infection with RSV and strep pneumonia, it potentiates somehow strep pneumonia. Without diving into too much details, but strep pneumonia has specific type of proteins that's called penicillin binding proteins. And these are actually the proteins that the penicillins, or I should say all the beta-lactamase antibiotics actually bind to and inhibit the bacterial growth, because these proteins are important in the cell wall synthesis of the bacteria. So by binding to them, they this allows them of functioning well, so there won't be cell wall synthesis and the bacteria will not thrive. What happens with co-infection with RSV is RSV was found to bind to that protein, and it sort of disallows the binding of the antibiotics to that protein, which allows the bacteria to thrive. So again, think of antibiotics. Usually you'll find that these patients will go on at least probably 2 weeks of antibiotics, namely coamoxiclav and azithromycin as a second line. And sometimes they would come in and they would be very poorly, history of weight loss, looking very miserable, and that should draw your attention to what we call ABPA, short for allergic bronchopulmonary aspergillosis, which is, as the name alludes to, it's an allergic reaction. It's an allergic reaction to inhalation of aspergillus spores, and the mainstay of treatment for these patients would be steroids and antifungals. Abdominal pain is also a big part of cystic fibrosis. We did mention reflux before. However, the more alarming abdominal pain in cystic fibrosis would be the lower abdominal pain and the constipation. And there is a specific type of syndrome that's called distal intestinal obstruction syndrome, which is quite a little bit of a dialed down version of meconium ileus that the babies have, but this happens later in life. The interesting part of this is that it actually can mimic appendicitis pain. It can't, because it most commonly happens in the distal ileum. So these patients can actually often get colicky, right inferior, right iliac fossa pain, vomiting, diarrhea, and sometimes they would get a false diagnosis of appendicitis, and sometimes they could also get operated on. So this is just to put it in the back of your mind, especially if the patient is known to have CF. This would be the first thing to look for. And the treatment will be just simply fluids and probably fecal disinfection with Movicol or Macrogol. Dehydration as well is a big part of it, because these patients lose chloride in the sweat. Sometimes in cystic fibrosis patients, the chloride that is lost in the sweat can reach up to more than 90 millimole per liter. And the problem is they don't just lose chloride, water follows and sodium follows as well. And this can get the kidneys angry, so kidneys will be determined to preserve sodium, and they do that by retaining sodium in the distal collecting tubule. And this is what you get in the end, pseudobarter, in which sodium is retained in the distal collecting tubule, but this is at the expense of other ions as well, like potassium and hydrogen ion. So getting a urine sample and probably measuring the acidity of the urine will be beneficial in these patients, because hydrogen ion is lost in the urine. pH would be acidic, probably less than 5.5 or 5. And treatment is, of course, IV fluids. The last presentation that these patients could come in is blood in the form of hemoptysis or hematemesis. This is more urgent. You'll find them in ED more than anything. This happens more in late teen years, especially hemoptysis. They will get infections that are eroding to the small blood vessels in the airways, and these need to be covered by antibiotics, of course, as well. And there is a liver disease that is related to cystic fibrosis, which is called cystic fibrosis liver disease. It happens, I think, in between 20 to 30% of patients with cystic fibrosis. Also, happens a bit late. Liver disease happens. They can have portal hypertension as a consequence to cirrhosis, of course, and then esophageal varices, which can bleed at any moment, and they would be presenting to ED. Of course, they will be needing to be taken to be resuscitated. So the last slide and the take-home message here is that if a child with CF arrives with a new onset shortness of breath or chest pain, chest X-ray is paramount in these patients, because quite more often than not that they might have pneumothorax. So this is very important. I know it doesn't really add anything, because if the patient comes in with new onset shortness of breath or chest pain, They will have an X-ray anyway, but just something to get in the put in the back of your minds. And thank you. Sorry, I tried to speak quickly and sort of cram everything up, but just for the sake of the time. Thanks.
Good basic overview, I think.
Yeah.
Questions, anyone?
Any questions? Right.
But it's, as you said, important that 2007, only since then.
Yes, exactly. So you,
And still gets occasionally, isn't it? But I think as we are reaching to the
So you can
14
actually
year,
get-
15 years.
yeah. So you can exactly. So you could probably get a patient that is 16 years and he or she didn't have the screening. So
Screening, yeah.
it is still in that window time. Yeah.